This presentation will provide an update regarding concerns surrounding two types of medications in the setting of aortopathy: calcium channel blockers and fluoroquinolones. I have no relevant conflicts to disclose. Calcium channel blockers are a class of antihypertensive agents that have been commonly used in patients with aortic disease, including as an alternative to beta blockers in patients with Marfan syndrome. Calcium channel blockers have been presumed to be beneficial in patients with aortopathy. For example, the drugs have been shown to effectively reduce systolic pressure in Marfan syndrome patients. Further, in the IRAD cohort, which includes patients with sporadic and heritable aortic dissection, calcium channel blocker use was associated with improved midterm survival in patients with type B dissection, as shown in the survival curve. Concern about potential deleterious effects, however, were raised by this study from Doyle and colleagues in the Dietz lab at Johns Hopkins. They found that both amlodipine and verapamil significantly exacerbated proximal aortic manifestations in Marfan mice, as illustrated on the right. Of note, losartan prevented amlodipine-induced ascending aortic aneurysm growth. In the same paper, the authors reported the results of a case control study using patients enrolled in the GenTAC registry. They found that Marfan patients with native aortic roots at enrollment who received calcium channel blockers had an increased odds of aortic dissection and of undergoing aortic root surgery compared to patients receiving other antihypertensives. Further, patients with non-Marfan forms of heritable disease who received calcium channel blockers also had increased odds of undergoing aortic root surgery. Based on this combination of experimental and clinical data, the authors suggested that calcium channel blockers should be used with caution in Marfan patients and perhaps in other heritable forms of aortopathy. Now we'll discuss fluoroquinolones, one of the most commonly prescribed classes of antibiotics in the United States. We'll start by reviewing the existing regulatory warnings. In October 2018, the European Medicines Agency, which is the EU's equivalent to the US FDA, released a formal warning stating that fluoroquinolones should be used with caution in patients with predisposing risk factors for aortic aneurysm and dissection. 2 months later, the US FDA followed suit and released a similar warning stating that healthcare professionals should avoid prescribing fluoroquinolones to patients who have an aortic aneurysm or are at risk for an aortic aneurysm. Summarized here are the similarities and important differences in the two warnings. Both organizations warn against fluoroquinolone use in patients with existing aneurysm or dissection, genetic aortopathies, hypertension, or known atherosclerosis. The EMA extended their warning to patients with a family history of aneurysm or dissection and patients with aortitis, while the FDA extended theirs to include elderly patients. In my view, both organizations overstepped here by including patients with hypertension, atherosclerosis, and advanced age. As we will discuss, there is no evidence supporting that fluoroquinolones precipitate aortic complications in these groups. Now let's assess the evidence that does exist. The available evidence comprises a series of large retrospective clinical studies and 2 laboratory studies using established animal models. First, our group examined how often patients at risk for aortic rupture are exposed to these agents. Using the Advisory Board Billing and Administrative Database, we identified nearly 100,000 patients with aortic aneurysms or dissections and found that 20% of these patients received a fluoroquinolone during their admission. Further, we identified nearly 1,900 patients with Marfan syndrome and found that 14% received a fluoroquinolone during their hospitalization. We concluded that a substantial proportion of patients who are at risk for aortic complications receive fluoroquinolones while in the hospital. This, of course, grossly underestimates the problem because we were unable to evaluate outpatient prescriptions. Let's now review the clinical studies that have explored whether fluoroquinolone exposure is associated with aortic aneurysms and dissections. There have been 6 studies, and very importantly, all have been retrospective studies involving analyses of national or regional administrative databases. There have been no prospective clinical studies. The key difference between the studies has been in their design and how the comparison group was defined, which has major implications when interpreting results. The first set of studies compared fluoroquinolone exposure to simple non-exposure, which introduces several problems related to potential confounding factors. Nonetheless, 3 studies using different designs found that patients exposed to fluoroquinolones had an increased risk of aortic disease compared to those who had not been exposed. In an attempt to manage confounding factors related to infection, 2 studies compared fluoroquinolone exposure to amoxicillin exposure. Both found an association between fluoroquinolones and aortic disease. However, in the study published this month in JAMA Internal Medicine, the authors conducted a secondary analysis that addressed surveillance bias by including only patients who had relevant baseline imaging. Applying this restriction to the cohort eliminated the association between fluoroquinolones and disease. That same study also compared exposure in patients with specific infection indications. They found that exposure to fluoroquinolones was associated with increased risk of aortic disease when compared to azithromycin in patients with pneumonia, but not when compared to trimethoprim sulfamethoxazole in patients with urinary tract infection. Finally, in another paper published this month, the authors investigated whether it is actually infection rather than a specific antibiotic that is associated with aortic disease. Their nested case control study found that aortic aneurysm and dissection were strongly associated with infections, but not with exposure to fluoroquinolones compared to other antibiotics. They concluded that the findings suggest that concerns about aortic aneurysm and dissection risk should not deter fluoroquinolone use for patients with indicated infections. We'll come back to this statement later. Importantly, all of these clinical studies have major limitations related to their retrospective nature, the use of administrative data, design flaws, and the many opportunities for bias. It must be emphasized that the studies focused entirely on the association between fluoroquinolone exposure and aortic disease in the general patient population, and none of the studies addressed the risk of fluoroquinolone use in patients with existing aortic disease or the risk of fluoroquinolone exposure in patients with heritable aortopathy. Switching to the laboratory studies, we have completed 2 studies using established mouse models. The first used wild-type challenged mice that were challenged with high-fat diet and angiotensin II infusion. Compared to challenged control mice, challenged mice that received ciprofloxacin had significant increases in rates of aortic aneurysm, dissection, and fatal rupture. Importantly, wild-type mice that received Cipro but were not challenged with high-fat diet or angiotensin II did not develop aortic disease, suggesting that the drug does not cause de novo disease in the absence of some type of aortic risk factor. In our second study, which is in press in JTCVS, we studied the effect of Cipro in a mouse model of Marfan syndrome. Compared to unexposed Marfan mice that received Cipro had significantly more rapid progression to severe aneurysm, dissection, and fatal rupture, supporting the conclusion that this drug should be avoided in patients with Marfan syndrome. Although I recognize that it is a stretch to make this leap to a clinical recommendation, it is unlikely there will ever be a rigorous clinical study to support it, so I believe that the mouse data is concerning enough to argue for a change in clinical practice. Taking all of this into account and coming back to the concluding statement by Dong and colleagues, I believe the appropriate conclusion is that the findings suggest that concerns about aortic aneurysm and dissection risk should not deter fluoroquinolone use for patients with indicated infections, provided they do not have existing aortic dilatation or dissection and do not have heritable aortopathy. To conclude by summarizing what we really know, data suggests that calcium channel blockers may be beneficial in patients with type B dissection, but should be used with caution in patients with Marfan syndrome and other forms of heritable aortopathy. Whether fluoroquinolones cause aortic aneurysm or dissection in patients without pre-existing aortopathy remains unclear. However, studies using established mouse models support that fluoroquinolones should be avoided in patients with aortic dilatation and in those at risk for aneurysm and dissection. I wish to acknowledge the research support that made the laboratory experiments possible, as well as my collaborators and our terrific research team. Thank you for watching this presentation. I look forward to further discussion during the summit.